Question 1. A client in an outpatient substance use disorder treatment program frequently misses appointments, is often late, and has not completed any assigned homework. Which of the following best describes this client's likely stage of change according to Prochaska and Diclement's trans-theoretical model? A. Action. B. Contemplation. C. Pre-contemplation. D. Maintenance. Answer: C. Pre-contemplation. This question tests your understanding of Prochaska and Diclement's stages of change. The keywords frequently misses appointments, often late, and not completed any assigned homework are strong indicators that the client does not yet recognize a problem or is unwilling to change, which is characteristic of the pre-contemplation stage. In this stage, individuals are unaware or underaware of their problem, or they are unwilling to make an effort to change. For example, a client might be court-ordered to treatment but internally resists the idea that they have a problem. Remember, in pre-contemplation, the client isn't thinking about changing their behavior in the near future. Question 2. A counselor is working with a client who reports using opioids to cope with chronic back pain. The client states, "I know I need to stop using so much, but it's the only thing that helps me get through the day." Which motivational interviewing, MI, technique would be most appropriate for the counselor to use in response to this statement? A. Giving direct advice on how to stop opioid use. B. Challenging the client's denial about their addiction. C. Exploring the client's ambivalence with reflections and open-ended questions. D. Emphasizing the negative consequences of continued use. Answer: C. Exploring the client's ambivalence with reflections and open-ended questions. This question focuses on applying motivational interviewing, MI, principles, specifically responding to client ambivalence. The client's statement, "I know I need to stop using so much, but it's the only thing that helps," clearly expresses both a desire for change and a resistance to it, which is the definition of ambivalence. MI is designed to help clients resolve this ambivalence by exploring their own reasons for change talk, and strengthening their commitment, rather than directly confronting, advising, or challenging them. For instance, the counselor might say, "So, on one hand, you see the need to stop, and on the other, you find the opioids helpful for your pain." This approach fosters a collaborative environment and respects client autonomy. Question 3. What is the primary purpose of a comprehensive psychosocial assessment in substance use disorder treatment? A. To determine the client's eligibility for financial assistance. B. To gather information for a holistic understanding of the client's needs and to inform treatment planning. C. To diagnose co-occurring mental health disorders exclusively. D. To predict the likelihood of relapse after treatment completion. Answer: B. To gather information for a holistic understanding of the client's needs and to inform treatment planning. The primary purpose of a comprehensive psychosocial assessment is to obtain a broad and deep understanding of the client's life circumstances, including their substance use history, mental health, social support, cultural background, medical history, legal issues, and strengths. The keyword comprehensive highlights the need for a holistic view, which is essential for developing an individualized and effective treatment plan. While it may touch on mental health or relapse risk, its main goal is not exclusive to those areas, nor is it about financial eligibility. For example, understanding a client's living situation and employment status helps tailor support for their recovery journey. Remember, a good assessment looks at the whole person, not just their substance use. Question 4. A counselor is developing a treatment plan for a client. According to best practices, which characteristics should be present in the client's goals and objectives? A. They should be broad and general to allow for flexibility. B. They should be determined solely by the counselor's professional assessment. C. They should be measurable, achievable, relevant, and time-bound, SMART. D. They should primarily focus on long-term abstinence without intermediate steps. Answer: C. They should be measurable, achievable, relevant, and time-bound, SMART. This question addresses a core principle of effective treatment planning. The best practice for setting goals and objectives, often described by the acronym SMART, emphasizes that they should be specific, measurable, achievable, relevant, and time-bound. This approach ensures clarity, accountability, and the ability to track progress, which is crucial for both the client and the counselor. Goals that are broad, counselor-determined, or solely focused on distant outcomes without intermediate steps are less likely to be effective. For instance, instead of client will stop using drugs, a SMART goal would be client will attend 2 NA meetings per week for the next 4 weeks and report on their experiences to their counselor. Question 5. Which of the following ethical principles is most directly concerned with protecting a client's personal information shared during counseling sessions? A. Beneficence. B. Non-maleficence. C. Autonomy. D. Confidentiality. Answer: D. Confidentiality. This question directly tests your knowledge of ethical principles in counseling, specifically focusing on the protection of client information. Confidentiality is the ethical duty of a counselor to protect a client's private communications and information, ensuring that what is discussed in sessions remains private and is not disclosed to others without explicit permission or legal mandate. While other principles like beneficence, doing good, and non-maleficence, doing no harm, are vital, confidentiality specifically addresses the security of shared personal data. For example, a counselor cannot discuss a client's substance use history with their family members without the client's written consent. Always prioritize protecting your client's privacy, as it builds trust and creates a safe space for recovery. Question 6. A client in early recovery experiences intense cravings and anxiety whenever they drive past their old drug-buying neighborhood. This is an example of which phenomenon? A. Euphoric recall. B. Classical conditioning. C. Post-acute withdrawal syndrome, pause. D. Transference. Answer: B. Classical conditioning. This question assesses your understanding of learning theories applied to addiction. The client's experience of cravings and anxiety upon encountering a specific environmental trigger, the old neighborhood, that was previously associated with drug use is a classic example of classical conditioning. In this process, a neutral stimulus, the neighborhood, becomes associated with a drug's effects, the reward, leading to a conditioned response, cravings, anxiety, even without the drug's presence. Euphoric recall involves remembering only the positive aspects of drug use, and pause refers to long-lasting withdrawal symptoms. For instance, the smell of alcohol might trigger cravings for someone who used to drink heavily, even years after sobriety. Recognizing these triggers is crucial for relapse prevention. Question 7. A counselor notices that a new client, who is from a different cultural background, appears uncomfortable discussing their family history during the intake assessment. The counselor should primarily: A. Assume the client is being resistant and gently confront them. B. Refer the client to a counselor who shares their cultural background. C. Acknowledge the client's discomfort, express openness, and explore culturally appropriate ways to gather information. D. Focus only on the immediate substance use issues and postpone family history discussions indefinitely. Answer: C. Acknowledge the client's discomfort, express openness, and explore culturally appropriate ways to gather information. This question highlights the importance of cultural competence in counseling. When a client from a different cultural background shows discomfort, the most ethical and effective approach is to acknowledge their feelings and demonstrate cultural humility, which means being open to learning and adapting your approach. Directly confronting the client or prematurely referring them might damage the therapeutic relationship. Instead, the counselor should explore the reasons for the discomfort, perhaps by asking about cultural norms regarding family discussions, to find a respectful and effective way forward. For example, in some cultures, discussing family problems with outsiders is considered shameful. Understanding this allows the counselor to adjust their approach, perhaps by building rapport first or using different lines of inquiry. Question 8. What is the primary reason for conducting a thorough risk assessment, including suicide and homicide potential, during the intake process for a client with a substance use disorder? A. To determine appropriate billing codes for insurance purposes. B. To fulfill administrative requirements for program admission. C. To ensure client and community safety and inform immediate intervention strategies. D. To predict the client's long-term prognosis for recovery. Answer: C. To ensure client and community safety and inform immediate intervention strategies. This question emphasizes the critical role of risk assessment in client safety. The primary reason for conducting a thorough risk assessment, especially concerning suicide and homicide, is to protect the client and others by identifying immediate threats and implementing appropriate safety interventions. While other options might be secondary outcomes, safety is paramount and requires urgent attention. For instance, if a client expresses suicidal ideation with a plan and means, the immediate goal shifts from standard intake to crisis intervention and safety planning. Always prioritize the safety and well-being of your clients and the community. Question 9. In the context of substance use disorders, what does tolerance refer to? A. The psychological need for a drug to avoid withdrawal symptoms. B. The process by which the body adapts to a drug, requiring larger doses to achieve the same effect. C. The intense desire or urge for a drug. D. The unpleasant physical and psychological symptoms that occur when a substance is reduced or stopped. Answer: B. The process by which the body adapts to a drug, requiring larger doses to achieve the same effect. This question tests your understanding of a fundamental pharmacological concept related to substance use. Tolerance refers to the body's adaptation to a drug, meaning that over time, an individual needs increasingly larger doses of the substance to achieve the desired effect or high. This is distinct from physical dependence, the body's need to avoid withdrawal, psychological dependence, intense craving, or withdrawal itself, symptoms upon cessation. For example, someone who initially felt euphoria from one drink might eventually need several drinks to feel the same level of intoxication, demonstrating increased tolerance. Recognizing tolerance is a key indicator of developing a substance use disorder. Question 10. A counselor is leading a psychoeducational group about relapse prevention strategies. A client states, "I keep trying to stay sober, but I always mess up when I'm around my old friends. It just feels hopeless." The most effective response from the counselor would be to A. Tell the client they need to find new friends. B. Validate the client's feelings and explore specific high-risk situations and coping mechanisms. C. Remind the client of the consequences of relapse. D. Advise the client that relapse is a normal part of recovery. Answer: B. Validate the client's feelings and explore specific high-risk situations and coping mechanisms. This question assesses effective group counseling and relapse prevention skills. The client's statement expresses feelings of hopelessness and identifies a specific relapse trigger, old friends. The most effective response is to validate their struggle. It sounds like you're feeling really discouraged and challenged by your old friendships, and then pivot to problem solving by exploring the specific high-risk situations and developing coping strategies. Simply telling them to find new friends, reminding them of consequences, or just stating that relapse is normal without further exploration is less helpful than a proactive, client-centered approach. For instance, the counselor might ask, what specifically happens when you're with those friends, and what are some ways you could handle those moments differently? Question 11. What is the primary goal of harm reduction strategies in substance use treatment? A. To enforce complete abstinence from all substances. B. To minimize the negative health, social, and economic consequences associated with substance use. C. To exclusively focus on the legal consequences of substance use. D. To immediately transition all clients into inpatient treatment. Answer B. To minimize the negative health, social, and economic consequences associated with substance use. This question tests your knowledge of harm reduction, a widely accepted approach in substance use treatment. The primary goal of harm reduction is to reduce the adverse effects of substance use without necessarily requiring complete abstinence as the initial or sole goal. It acknowledges that not everyone is ready or able to achieve abstinence immediately, and focuses on practical, realistic steps to improve health and safety. For example, providing clean needles to intravenous drug users is a harm reduction strategy that aims to prevent the spread of diseases like HIV and hepatitis, even if the individual continues to use. It's about meeting people where they are and reducing suffering. Question 12. Which document provides the standardized diagnostic criteria for substance use disorders used by clinicians in the United States? A. International Classification of Diseases, ID. B. Physician's Desk Reference, PDR. C. Diagnostic and Statistical Manual of Mental Disorders, DSM-5-TR. D. American Society of Addiction Medicine, ASAM Criteria. Answer C. Diagnostic and Statistical Manual of Mental Disorders, DSM-5-TR. This question is about the standardized diagnostic reference in the field. The Diagnostic and Statistical Manual of Mental Disorders, currently in its 5th edition, text revision, DSM-5-TR, is the authoritative guide published by the American Psychiatric Association that outlines the diagnostic criteria for all recognized mental health conditions, including substance use disorders. While the ICD is another diagnostic system, used internationally and for billing, and ASAM provides placement criteria, the DSM-5-TR is specifically what clinicians in the U.S. use for diagnosing SUDs. For instance, to diagnose an opioid use disorder, a clinician would refer to the specific criteria listed in the DSM-5-TR. Question 13. A client reports feeling pressured by their family to attend more 12-step meetings than they are comfortable with. The counselor should primarily uphold the ethical principle of A. Beneficence. B. Fidelity. C. Autonomy. D. Justice. Answer C. Autonomy. This question focuses on the ethical principle of client autonomy, which is central to client-centered practice. Autonomy refers to the client's right to self-determination and to make their own choices about their treatment and recovery path, free from coercion. While family input can be valuable, the counselor's role is to support the client's right to decide what feels right for them, even if it differs from family expectations. For example, if a client prefers individual therapy over more meetings, the counselor respects that choice while exploring the reasons. Always empower your clients to make informed decisions about their own lives and treatment. Question 14. A counselor suspects a client is experiencing symptoms of acute opioid withdrawal. Which of the following symptoms would be most indicative of this condition? A. Bradycardia and constricted pupils. B. Rhinorrhea, muscle aches, and pupillary dilation. C. Sedation and respiratory depression. D. Increased appetite and constipation. Answer B. Rhinorrhea, muscle aches, and pupillary dilation. This question assesses your knowledge of the physical signs of opioid withdrawal. When someone is acutely withdrawing from opioids, common symptoms include flu-like manifestations such as a runny nose, rhinorrhea, muscle aches, nausea, diarrhea, and dilated pupils, mydriasis. Bradycardia, slow heart rate, constricted pupils, meiosis, sedation, and respiratory depression are typically symptoms of opioid intoxication or overdose, not withdrawal. For example, a client experiencing opioid withdrawal might look like they have a severe cold, with watery eyes and a frequent need to stretch their limbs due to discomfort. Being able to recognize these signs is crucial for appropriate assessment and intervention. Question 15. A client completes treatment and is entering the maintenance stage of change. What is a key focus for counseling at this stage? A. Exploring past trauma as the root cause of addiction. B. Developing new skills to prevent relapse and sustain recovery. C. Increasing awareness of the problem and the need for change. D. Confronting denial and addressing ambivalence. Answer B. Developing new skills to prevent relapse and sustain recovery. This question examines the focus of counseling within the maintenance stage of the stages of change model. In the maintenance stage, clients have successfully achieved their desired behavior change and are working to prevent relapse and consolidate their gains over the long term. The key focus here shifts from initial change to sustaining it, which involves developing robust coping mechanisms, strengthening support systems, and continually learning strategies to navigate life without returning to substance use. Exploring past trauma might be part of an earlier stage, and confronting denial or increasing awareness are characteristic of pre-contemplation or contemplation. For instance, a client in maintenance might work on identifying triggers, practicing refusal skills, and engaging in healthy new hobbies. Question 16. What is the primary purpose of a safety plan developed with a client who is experiencing suicidal ideation? A. To document the client's history of mental health issues. B. To serve as a legally binding contract to prevent self-harm. C. To provide a structured, practical, and individualized plan for the client to follow during a suicidal crisis. D. To determine if the client requires involuntary hospitalization. Answer C. To provide a structured, practical, and individualized plan for the client to follow during a suicidal crisis. This question addresses the critical role of safety planning in crisis intervention. A safety plan is a proactive, collaborative, and individualized document that outlines specific steps a client can take to remain safe when experiencing suicidal thoughts. It includes identifying triggers, coping strategies, distractions, and contact information for supportive individuals and crisis resources. It is not a legal contract, nor is its primary purpose to document history or determine involuntary hospitalization, though it may inform those decisions. For example, a safety plan might list calling a specific friend, going for a walk, or contacting a crisis hotline as steps to take when suicidal thoughts become intense. Question 17. The primary goal of a crisis intervention is to A. Provide long-term therapy for underlying issues. B. Stabilize the client's immediate situation and ensure safety. C. Conduct a comprehensive assessment of the client's history. D. Develop a detailed, multi-year treatment plan. Answer B. Stabilize the client's immediate situation and ensure safety. This question focuses on the core objective of crisis intervention. The primary goal of crisis intervention is immediate stabilization of the client's emotional and physical state, and ensuring their safety and the safety of others. It is a short-term, focused intervention designed to address an acute crisis, not to provide long-term therapy or detailed assessments, which come after the immediate danger is managed. For instance, if a client arrives at a clinic highly agitated and threatening self-harm, the crisis intervention would first involve de-escalation and safety measures. Remember, in a crisis, safety and stabilization are always the first priorities. Question 18. A counselor working in an outpatient setting becomes aware that a client has started selling illicit drugs to support their own habit. Ethically, the counselor's primary responsibility is to A. Terminate the client from treatment immediately. B. Report the client to law enforcement. C. Address the issue with the client within the therapeutic relationship, exploring risks and treatment implications. D. Ignore the information to maintain trust and confidentiality. Answer C. Address the issue with the client within the therapeutic relationship, exploring risks and treatment implications. This question presents an ethical dilemma that tests your professional judgment. While a counselor has ethical duties, reporting to law enforcement is generally not the primary step unless there is a clear and imminent danger to an identifiable third party, which is not stated here. The most ethical and therapeutic approach is to address the new information with the client within the boundaries of the counseling relationship. This involves exploring the risks associated with selling drugs, legal, safety, health, how it impacts their recovery, and its implications for their treatment plan. For example, the counselor might say, "I'm concerned about what you shared, and I want to talk about how this might affect your safety and your recovery goals." The aim is to guide the client towards healthier choices and assess their commitment to treatment, while upholding the therapeutic relationship as much as possible. Question 19. According to the ASAM criteria, what dimension primarily addresses a client's current withdrawal potential? A. Dimension 1. Acute intoxication and/or withdrawal potential. B. Dimension 2. Biomedical conditions and complications. C. Dimension 3. Emotional, behavioral, or cognitive conditions and complications. D. Dimension 4. Readiness to change. Answer A. Dimension 1. Acute intoxication and/or withdrawal potential. This question specifically tests your knowledge of the ASAM criteria, a widely used tool for assessing client needs and determining appropriate levels of care. Dimension 1 is explicitly designed to evaluate a client's risk of experiencing acute intoxication or withdrawal symptoms and their severity, guiding decisions about the need for medically managed withdrawal. The other dimensions focus on different aspects of the client's health and readiness. For example, if a client reports heavy daily alcohol use and abruptly stopped, an assessment in Dimension 1 would focus on the likelihood of severe alcohol withdrawal symptoms like seizures or delirium tremens. This dimension directly informs the need for medical monitoring and detox services. Question 20. What is a common characteristic of individuals experiencing codependency in relation to someone with a substance use disorder? A. Prioritizing their own needs and setting healthy boundaries. B. Enabling the substance user's behavior by consistently rescuing them from consequences. C. Encouraging the substance user to seek professional help and providing financial support. D. Maintaining emotional distance and detachment from the substance user's problems. Answer B. Enabling the substance user's behavior by consistently rescuing them from consequences. This question addresses the concept of codependency, particularly within families affected by substance use. A common characteristic of codependency is enabling behavior, where an individual, often a family member, inadvertently supports the substance user's continued use by protecting them from the natural consequences of their actions. This can include making excuses, bailing them out of trouble, or assuming their responsibilities. Prioritizing one's own needs and setting healthy boundaries are the opposite of codependent behavior, which often involves focusing excessively on others' needs. For instance, a codependent parent might repeatedly pay off their adult child's debts, preventing them from experiencing financial repercussions from their substance use. Question 21. Which of the following is an example of an open-ended question in a counseling session? A. Did you use any substances last week? B. How did you feel after that argument with your spouse? C. Are you ready to commit to abstinence? D. Is everything going well for you today? Answer B. How did you feel after that argument with your spouse? This question tests your understanding of a fundamental counseling skill, asking open-ended questions. An open-ended question is designed to elicit more than a simple yes or no answer, encouraging the client to elaborate, reflect, and provide detailed information. Questions beginning with how, what, or tell me about are typically open-ended. The other options are closed-ended questions, which limit the client's response. For example, instead of asking "Are you sad?" an open-ended question would be "What emotions are you experiencing right now?" Open-ended questions are vital for gathering rich information and building rapport. Question 22. A client diagnosed with both major depressive disorder and alcohol use disorder is receiving integrated treatment. This approach is commonly known as A. Cross-addiction therapy. B. Dual diagnosis treatment. C. Concurrent disorder management. D. Co-occurring disorder treatment. Answer D. Co-occurring disorder treatment. This question refers to the standard terminology for treating clients with both a mental health disorder and a substance use disorder. When a client presents with both conditions, it is referred to as co-occurring disorders, and the most effective approach is integrated treatment, addressing both simultaneously. While dual diagnosis and concurrent disorder management are related terms and sometimes used interchangeably, co-occurring disorder treatment is the most current and widely accepted umbrella term in professional literature and practice. For instance, instead of treating depression in one clinic and alcohol use in another, an integrated program addresses both within the same therapeutic framework, recognizing their intertwined nature. Question 23. What is the primary purpose of a therapeutic alliance in addiction counseling? A. To ensure the counselor has complete control over the treatment process. B. To establish a collaborative, trusting, and respectful relationship between the counselor and client. C. To provide the client with a strong sense of dependency on the counselor. D. To strictly enforce the rules and boundaries of the treatment program. Answer B. To establish a collaborative, trusting, and respectful relationship between the counselor and client. This question focuses on a foundational element of effective counseling, the therapeutic alliance. A strong therapeutic alliance, also known as the working alliance, is a collaborative and positive relationship characterized by trust, respect, and shared goals between the counselor and client. This alliance is crucial for client engagement, motivation, and positive treatment outcomes, as it creates a safe space for the client to explore difficult issues and work towards change. It is not about control or fostering dependency, but rather about partnership. For example, a strong alliance allows a client to feel comfortable discussing a recent relapse without fear of judgment. Always strive to build a strong, collaborative relationship with your clients. Question 24. A client expresses a desire to reduce their alcohol intake but is not ready to commit to complete abstinence. Which of the following approaches aligns best with this client's current stage of readiness? A. Immediately prescribing antabuse, disulfiram. B. Focusing solely on the negative health consequences of alcohol use. C. Exploring controlled drinking strategies and harm reduction techniques. D. Insisting on a residential treatment program for detoxification. Answer: C. Exploring controlled drinking strategies and harm reduction techniques. This question again touches on the importance of meeting the client where they are, reflecting the principles of harm reduction and stages of change. If a client expresses a desire to reduce alcohol intake but is not ready for complete abstinence, exploring controlled drinking strategies or other harm reduction techniques is the most appropriate and client-centered approach. Directly prescribing medication for abstinence, focusing exclusively on negative consequences, or insisting on residential treatment might alienate a client who is not yet committed to that level of change. For instance, the counselor might discuss setting limits on drinking days, alternating alcoholic with non-alcoholic beverages, or avoiding high-risk drinking environments. Question 25. What is the primary ethical consideration when a counselor receives a subpoena for a client's records? A. Immediately release all requested documentation to avoid legal repercussions. B. Inform the client of the subpoena and seek their consent before releasing any information. C. Contact the prosecuting attorney to understand the charges against the client. D. Consult with a legal professional and consider asserting privilege on the client's behalf. Answer: D. Consult with a legal professional and consider asserting privilege on the client's behalf. This question addresses a complex ethical and legal situation regarding client confidentiality and subpoenas. The primary ethical consideration is to protect the client's confidentiality while adhering to legal obligations. Simply releasing records or ignoring the subpoena is inappropriate. The counselor should inform the client, if possible and legally permissible, consult with a legal professional, such as an attorney specializing in mental health law or agency legal counsel, and potentially assert therapist-client privilege, as many states protect these communications. The goal is to release only the minimum necessary information, if legally required, after exploring all protective measures. For example, a legal professional can advise on the validity of the subpoena and the best course of action to protect the client's rights.